I'm president for the Southeast section. And for those of you who are not members yet, the goal of the Southeast chapter emulates the mission of the National Society at a regional level. And the mission is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. And today we are privileged to learn about salvage therapies for severe hypoxic respiratory failure. But before we start, I want to thank the section leadership and our committee chairs for making this event possible. I especially want to thank Dr. Saberi and Jade and all the other help that we've received from WellStar and the individuals that we worked with to also make this event possible. So thank you so much for that. I'd like to thank Janssen, Hospira, and Otsuka for being our exhibitors this evening and offering their support for our chapter as well. I'd like to encourage anyone who is not a Southeast section member to talk to our leadership today. We have a couple committee members and chairs around the room about how you can become a member and how you can sign up. We had a lot of information up here on our screensaver as well, so I hope you caught some of that. So without further ado, it's my honor to introduce tonight's speaker, Dr. Asif Saberi. And Dr. Saberi is an intensivist practicing here at WellStar Kennestone. He's also an associate professor for the Mercer University School of Health Sciences and medical director for the Physician Assistant Program with Mercer University. He is board certified in pulmonology and critical care, and he has been engaged in the management of critically ill patients for many years. Dr. Saberi will be sharing his insights today on salvage therapies for severe hypoxic respiratory failure. Thank you.
Thank you very much. Thank you for that very generous welcome and introduction. Which should I be using?
Both. So one is for the webinar and then one.
Okay, let me put this in this pocket and put this in this pocket. All right.
Thank you so much.
Can everybody hear me well?
Squeeze behind you.
Sure, thank you. Let me make sure my laser is working right. It is. Okay. Well, first and foremost, thank you very much for that very generous introduction. The Southeast chapter of the Society for Critical Care Medicine is a great resource, and I am glad that we are now working collaboratively. I hope our group, with more than 70 clinicians in the group, as well as I don't know how many hundreds, maybe thousands of other clinicians within the hospital, will become members and will be a very prominent part of the SCCM meetings in future. I will be discussing some brand names and proprietary terms, as well as some off-label treatments. I have no conflicts to declare. When I was first approached to talk about salvage therapies, I pondered how best to approach this. And it was timely that we are in the process of rewriting our respiratory failure protocols here at WellStar's healthcare system. And a few months ago, I was approached, along with several of my clinicians, also to conceive of a bigger plan. I think we have positive feedback. Okay. Conceive of an overall schema for approaching patients with very severe hypoxic respiratory failure. And I will attempt to recreate how we develop this approach to severe hypoxic respiratory failure and make the case for that approach. So just to give you a little background, what is ARDS? We all are familiar with the terminology. It first recognized in the 1960s, but it wasn't until the very end of the 1980s that there was a consensus on how to define it so that it could be studied systematically. And the consensus definition of ARDS, with which you are all familiar, includes the criteria of acute onset, a frontal radiograph showing bilateral infiltrates, as well as a certain amount of clinical certainty that this was not being caused by left atrial hypertension. If the PF ratio, the PaO2 to the FiO2 ratio, was less than 300, it is defined as acute lung injury. And if it is less than 200, it is defined as ARDS. acute lung injury is considered a minor form of ARDS. This definition changed a little bit more recently by what is called the Berlin definition or Berlin Conference, where the term acute lung injury is no longer to be used and it's abandoned and it's supplanted now by mild ARDS. The definition is the same, a PF ratio of 300 to 200. Two other terms now emerge, moderate ARDS, where the PF ratio is between 200 and 100, and severe ARDS, where the PF ratio is less than 100. You could find the chest X-ray abnormalities on CT as well now. Onset had to be within 7 days of an insult. And very importantly, you no longer need to exclude heart failure. This has very significant clinical implications because in the past, if you had somebody with heart failure, the argument was that they were not at risk for acute lung injury, and therefore they ought not to be treated with protective lung ventilation. That is no longer the case. So you could have heart failure, and if you had risk factors for acute lung injury, such as, for example, a long time on pump, that person would qualify for the definition of ARDS. You would only do an echo if there was no other explanation to describe what you were seeing, bilateral infiltrates, hypoxia, etc. So that is the new definition. In terms of therapies, this is my schema for defining the therapies that we'll be discussing. Conventional therapies are the ones that the ARDS-net original studies used, which were pressure preset and volume preset. APRV in 2009, if you folks remember, was defined as salvage therapy. But I do not consider this salvage therapy anymore because it's become very common in our practice, and we use this for patients with severe hypoxemia in what we term as open lung ventilation. Neuromuscular blockade, once the anathema of critical care medicine, is re-emerging based upon a very robust study that perhaps there's a role for this. And then, of course, we have the salvage therapies, high-frequency oscillatory ventilation, which has recently had some bad press. Inhaled vasodilators, again, vilified. Recruitment maneuvers, we won't be talking a great deal about this, but if you have questions, I'll be happy to answer those towards the end. Prone ventilation, maybe some light at the end of the tunnel, and of course, ECMO, which has become of interest to people. The pivotal study which changed everything about how we approach patients with hypoxic respiratory failure is this study. Some people call it the ARMA study, A-R-M-A. And this study involved the comparison between low tidal volume ventilation. Patients in the treatment arm were treated with 6 milliliters per kilogram predicted body weight, tidal volume, and their airway distension pressures were constrained to 30 centimeters of water. And this was compared with what was then the norm, which was to allow tidal volumes to be much higher, as high as 15 milliliters, although in the control arm, the average tidal volumes were about 11 milliliters per kilogram predicted body weight. And airway distension pressures could be as high as 50. It's unimaginable these days, but that's how high the pressures could be in the control arm. And what this study showed is that with the lower tidal volume and constraining the airway distension pressure, you conferred a significant mortality benefit to the patients who were treated in this manner. The absolute risk reduction was 9%, which means 9% less people died, and you had to treat only 11 people to save one life. This changed everything about how we treat respiratory failure, and it's meaningful that it was published in 2000, the year that I started my pulmonary and critical care fellowship. About the same time that the ARDS network was publishing its ARMA study, there were other smaller studies. Amato in South America, for example, did studies in patients using smaller tidal volumes because it was believed that smaller tidal volumes may be protective. But he allowed higher PEEPs, the positive end expiratory pressures, to be used, deciding on the PEEP based upon very physiological exercises. He studied the compliance curve of the lungs in these patients and used PEEPs that were higher than the PEEPs that were used in the ARMA study. And he claimed among his 50 to 60 patients that he published that there was better survival benefit using higher PEEPs. So this was of interest to people. And this study, for example, much later study in 2006 is exemplary of the kind of fascination people had with higher PEEP, the so-called open lung approach. In this study, you see that the patients who were treated with low tidal volume but higher PEEPs, they had many more ventilator-free days. They had much less mortality. But what's interesting is that the control arm had much higher mortality than you would expect to find in a patient treated with low tidal volume ventilation. And that's because this was also about the same time when, if you went to the SCCM or the ATS, you had this vigorous debate about whether or not 6 mLs is the right amount of tidal volume to use, and that 11 is bad, but what about what's in between? So these people actually used tidal volumes of 9 mLs per kilogram. So it's not surprising that they had much higher mortality than would be expected for patients treated with lung protective ventilation, 6 mLs per kilogram, for example. So the ARDS network did its own study. It's called the alveoli study, where, I apologize. Okay. The alveoli study, where they had both the treatment as well as the control arm placed on lung protective ventilation, 6 mLs per kilogram. They used higher tidal volumes, kind of like the way that Amato had done in his studies, as well as other people who had emulated it. And they found that there was no survival benefit to either of them. In fact, they felt that the patients had longer time to discharge and maybe did a little worse in the long run when they were placed on higher PEEPs. And the conclusion of the study was higher PEEPs, not really good. Now, there was, by this time, a lot of data on comparing higher PEEPs to lower PEEPs. So this meta-analysis, which was published in 2010, compared data from several of these studies and found that in the aggregate, when you look at all patients with ARDS and acute lung injury, when they were treated with low lung protective ventilation and higher PEEPs, they did no differently from people who were treated with lower PEEPs, like the ARMA study. But when you break down the patients who were the sickest, patients who had a PF ratio less than 200, they did better in terms of hospital mortality as well as time to unassisted ventilation. But if you look at only the patients who were not so sick, here what they mean by patients without ARDS is patients whose PF ratio was greater than 200, which means acute lung injury, they did worse. So it appears that higher PEEP has a role in patients who were the sickest, but lower PEEPs were probably better in people who had acute lung injury and perhaps also moderate ARDS, what is called moderate ARDS these days. This is another study that was published by Grasso from Italy during the 2009 H1N1 epidemic. So these people ran an ECMO program, and they looked at all the patients, about 25 of them, not huge numbers, who had been referred to them for ECMO. So these people obviously were people who were being ventilated with low tidal volumes, optimal amount of PEEP, etc. Because Italy is a big proponent. Most of the papers from Italy, they are big proponents of using high tidal volumes. What they found is that half of these patients could be treated with invasive mechanical ventilation, that is without ECMO, if you optimize their PEEP. So even though these people were on higher PEEPs, towards a higher end of PEEPs according to the ARDS network table of PEEP, these people were still not on optimal PEEP. So what did they do? In patients who have abdominal distension, for example, we often see very high peak airway pressures. Therefore, the plateau pressures are also higher. Patients who have significant chest wall edema and patients who have subcutaneous emphysema, and many of these patients do, they have a significant positive pleural pressure that is conferred from outside their chest cavity. This is reflected in the pressures that we measure at the alveolar, at the ventilator inlet, the peak airway pressure. So in this example, what you're looking at over here is an airway pressure tracing. Over here, you have an esophageal pressure tracing. And here you have the difference of the two. In this setting, if you looked at this alone, you can tell that the patient is on a PEEP of about 10. And the peak airway pressure is almost 40. Here, an inspiratory whole maneuver is being conducted, and you see that the plateau pressure is almost 40, which defies what you ought to be doing according to the ARDS network study, right? Because it's much higher than 30. But the esophageal pressure, which is a surrogate for pleural pressure, is almost 24 in this patient. So when you take esophageal pressure out of this pressure, this is the tracing you get, and you see the peak airway pressure is much more modest. It's about 15. Plateau pressures are 15 as well. So in these patients, if you increase the PEEP, so from here, this is a scale of 60. Here, there's a scale of 40. So here, the PEEP went up to about 25, right? You see the peak airway pressure is almost 50. Plateau pressure is very close to 50. But when you take the esophageal pressure out, you see that the peak airway pressure is about 25, and plateau pressure is just less than 25, which is very much more manageable and consistent with the lung protective ventilatory strategy. Of course, we don't have a good way of measuring esophageal pressures. I've tried it once with a Fogarty balloon. It's not pleasant. But today, you do have a product that's available. It's made by CareFusion, and we are going to evaluate that to see in our worst patients if we're doing a good job of giving them enough PEEP. What are the other ways by which you can optimize PEEP? So many of you probably already do this. Incremental PEEP, where you keep increasing the PEEP until you find that the compliance, which increases in a linear manner, stops to increase and plateaus off. You know that you have reached the top of the compliance curve and back off to the previous PEEP. So that's one way of doing it. Decremental PEEP is basically you starting at a very high PEEP and then decreasing the PEEP until you see the compliance fall. That suggests to you that on the sigmoid-shaped curve of the lung compliance, you have reached the bottom of the curve, so you need to be on a slightly higher PEEP. So the idea is that you want to ventilate these patients between the upper inflection point and the lower inflection point of the pressure volume curve of the lungs. And that is the decremental PEEP. Now, there's another interesting way that has been described. It's called the stress index measurement. This can only be done when patients are on volume-controlled ventilation, and they have to have a constant flow, which means that the flow cannot be changing. So the patients can't be on PRVC, for example. And when you have that kind of a flow, you see a square waveform on the flow tracing, and these three are the pressure tracing. What you see over here is that the pressure is rising at almost linearly throughout the cycle. So as the constant flow is applied, pressure rises as increasing amounts of alveoli are recruited. So this is optimal amount of PEEP. Now look at this curve. Over here, you have a linear rise of pressure up to the midpoint, and then there is an inordinate increase in pressure following that, which tells you that at this point now you are over-distending some alveoli, and therefore the pressure is rising out of proportion to the inflation of the lungs. So you have too much PEEP over here. And when you see this kind of a curve where you have a steady increase in pressure with a convex upwards curve, it tells you that you can increase the PEEP even more. So a convex upwards, higher PEEP is warranted. Concave upwards, your PEEP is too much. This is just right. On the Mackay ventilators, which we have at WellStar, there is a software option which can be turned on. It costs money, I'm told. And it gives you an index. That makes it very simple to do. So if your index is 1, you're just right. If your index is more than 1, too much PEEP, less than 1, too little PEEP. But this is so easy to do. I'm not sure $1,000 a machine is warranted. In a PRESI, then, the standard of care for treating patients with ARDS is to use low tidal volumes, 6 milliliters per kilogram, constrain the plateau pressures to less than or equal to 30 centimeters of water, use an appropriate amount of PEEP, which for patients requiring lower FiO2s means using a PEEP such as the one in the ARMA table. That would be okay. But for patients with more severe ARDS, perhaps higher PEEPs are required, and you need to optimize it using one of those mechanisms we discussed. If only life would be that easy, right? There are a lot of challenges to implementing these simple steps. So in this study done by Peter Provenost at the Johns Hopkins Institute and the University of Maryland, there's about 5 educational hospitals that were involved in the study, about 500 patients. They did an observational study. 500 patients with a diagnosis of ARDS. They called and got the ventilator setting in the morning and got the ventilator setting in the evening. And what they discovered is that for these 500 patients with ARDS, the compliance with what the ventilator settings ought to be in order to keep the tidal volume low, keep the plateau pressure low, and optimize the PEEP, it was less than 60%. And these patients had a very significant mortality. They had 60% of these patients died over the course of 2 years that they followed them. And what they found also is that the more number of settings that were non-compliant with ARDS network kind of recommendations, the more the mortality. So each additional setting that you made compliant with ARDS, you protected the patient by about 3% mortality. So this is the approach that we have come up with here at WellStar, which is informed by the data I just shared with you. So bear with me while I walk you through this. All patients with hypoxic respiratory failure due to ARDS are treated with ARDS-net type of settings. Anybody who has severe hypoxia, so the PF ratio is less than 100, or you are requiring plateau pressures greater than 30 on tidal volumes of 4 ml. So when your plateau pressures rise, the algorithm is to decrease the tidal volume even less than 6 ml. Or you have an oxygen index that's greater than 30. Oxygen index is sort of the reciprocal of PF ratio. And you have severe hypercarbia that requires you to keep giving the patient buffer. That is when we would consider the patient for ECMO and at the same time evaluate the patient for recruitable lungs. What does that mean? So all of these patients who might go on ECMO require a lot of legwork before they can actually be placed on ECMO. So we need to start doing those things, but also see if these patients can be managed in other ways. What are those other ways? Is assess these patients by any of these means that I described earlier to see whether the PEEP was optimized and whether optimizing the PEEP improves the oxygenation. If it doesn't, then we would see whether the patient had contraindications for ECMO. If they did not, they would go on ECMO. And if they did, then we would use salvage therapies. Questions? Okay. Having said that, we'll move on to what I consider a non-conventional mode of therapy, APRV. APRV is, if done rightly, a way of doing open lung ventilation. So what is open lung ventilation? Higher PEEPs, but at the same time, constraining the mean airway pressures. Seems to be contradictory, but it really is not. One way of describing APRV is CPAP, but high CPAP pressures which are released from moment to allow ventilation to happen. All along, the patient is allowed to breathe. So if the patient has a respiratory drive and can ventilate themselves, they can breathe at a higher PEEP as well as the lower PEEP. And how does that work? So this is a graph of a patient on APRV. The first is the pressure tracing on time. The second is the flow tracing on time. And the third is a volume tracing on time. So in the pressure tracing, you can see that the pressure ramps up at the beginning of the cycle to a high pressure. Here it is about 45 or so. It's higher than what would be typically used, but this was a very unusual circumstance. And the pressure is held at that high level. That high level is called P high for a certain length of time that is called T high. So over here, you can see that these are 1 second markings. So the T high is 1, 2, and maybe 2.5 seconds. This is lower than what we would use usually, but these are unusual circumstances, as I mentioned. After holding it at P high for T high seconds, the pressure then drops. And it drops down to P low. In this case, P low is about 0. It's held at P low for a very short duration of time, and then the pressure goes back up to P high. During this time, the patient has his own spontaneous spreads. Those squiggles are his own spontaneous spreads. What is the purpose of dropping this? So these volumes are extremely small. Over here, the patient is registering a tidal volume of about 78 milliliters, extremely small. So these would not be adequate for ventilating this patient enough. But these are important volumes because each of the spontaneous breaths that the patient makes is made by creating negative intrapleural pressure and positive intra-abdominal pressure, which in turn squeezes the inferior vena cava, pushing blood back into the thorax and increasing the cardiac return, which in turn increases the cardiac output, which is the source of the salutary effects of APRV on cardiovascular system. But if you drop the high pressure down to 0 for too long a period of time, then any recruitment that happens at the high pressure is lost. So how do you manage this? This is how you manage it. So this is a flow tracing. At the beginning of the cycle, the flow is increasing. And here the flow stops. The pressure is constant, so the flow drops back to 0. The flow is changing a little bit because patient is making some breaths. And at the end of that T high, the flow drops negatively, allowing the patient to exhale. And that quickly reaches the highest point of negative flow, and then passively, the lungs start to empty. If the lungs were allowed to empty completely on their own, this is how long it would take. This is the projected time that the lungs would take to empty. If the patient had obstructive lung disease, for example, this tracing might look something like that, right? So if you allowed a patient with obstructive lung disease to be placed on APRV and allowed his T low to be that long, that patient would de-recruit during that period of time. But if you allowed his T low to be as low as it is over here, he might retain too much air. We know that we are creating a certain amount of auto PEEP in these patients. But that's because we are calculating that by constraining this time, T low, at about 50% of whatever the peak expiratory flow is, that we are not going to cause too much auto PEEP. And if we need to, we can actually decrease it to 75 to improve the recruitment. But we never allow it to go more than 50% so that we don't de-recruit the lungs. For the same reason, we wouldn't use this in a patient with obstructive lung disease. What about outcomes? Well, we know that physiological endpoints improve. Gas exchange improves, blood pressure improves in these patients, systemic pressures improve in these patients. The APRV graph I showed you at the beginning of this section was from a patient who came back after heart surgery, 9 hours of pump time, lung injury, on 4 vasopressors, and 100% oxygen with a PEEP of 12 on conventional mechanical ventilation, with oxygen saturations of about 80% and a PaO2 in the 40s. On APRV, within 24 hours, this patient had turned around. And I have another graph, which I chose not to put over here, from 24 hours later, where this patient was now on 50% oxygen. So, and practically off all vasopressors. So extremely gratifying mode of ventilation to use in patients who are adequately volume hydrated and do not have obstructive lung disease. You need to reduce sedation. In the studies, you found that you reduce sedation, but you need to reduce sedation in order to optimally use this mode of ventilation and to capitalize upon it. You cannot use it in patients with neuromuscular blockade. The only outcomes data that actually seems to be better is in the trauma patients, where length of stay on the mechanical ventilation and length of stay in the ICU is actually better with APRV in small studies. There's been no study that has shown an improvement in mortality, and I don't think that kind of a study can be done given the circumstances that we know about lung protective ventilation. Another non-conventional non-conventional therapy is neuromuscular blockade. When I trained in 2000, if somebody was put on neuromuscular blockade overnight, they really were grilled at rounds. This study was done not in a small population of patients, but almost 400 patients, randomized to get cis-atracurium infusion at the diagnosis of their ARDS for 48 hours. These patients had a PF ratio less than 150, so they were moderate to severely impaired. So they would fall into moderate or severe ARDS category today. And there's a huge difference in outcome. These patients this particular study has re-invoked the interest in using neuromuscular blockade. This is only for 48 hours, only for initial diagnosis of ARDS. And what's interesting is that in the two arms of the study, there was no more neuromuscular weakness in one or the other. So patients who were treated for 48 hours with cisatracurium did not have worsening muscular weakness and prolonged ventilation. What about high-frequency oscillatory ventilation? This is a fascinating mode of ventilation. We all love and hate it. There are some people who will never touch it. There are some people who love it. I'm somewhere in between, I will admit. So the way we plan to use it is as salvage therapy for ARDS, because that's what we think this data suggests. We don't write it off altogether. There's another indication is bronchopleural fistula. There have been small case studies where patients with severe bronchopleural fistula have been successfully treated with high-frequency oscillatory ventilation when they could not be managed with regular ventilation. How does it work? We know that the mechanism is extremely complicated, but to distill it down to simple terms, and I have a hard time understanding those mechanisms myself, this is how I say it. Very tiny lung inflation volumes, baby volumes, like 50 to 100 cc's, very high frequency, 3 to 12 hertz, 3 to 12 times every second. And the idea is that you recruit large number of alveoli by having a high mean airway pressure, but because your oscillating volumes are small and your peak airway pressure is lower than it would be with conventional ventilation, your plateau pressures are also much lower. Thereby, you minimize lung injury by preventing all of those three things that we know cause lung injury. So this is a graph that compares pressure-controlled ventilation with high-frequency ventilation. So in this patient with a PEEP of 10 and a peak inspiratory pressure of about 40, you can see the mean airway pressure is about 25. So when you convert somebody from conventional ventilation, typically we would put them on high-frequency oscillatory ventilation with a mean airway pressure about 5 times above the conventional ventilation. And so that's what was done over here. And you can see the oscillating pressures are much smaller. And the mean airway pressure is over here, but the peak airway pressure is even lower than what you find in patients with the pressure control, in this patient with pressure control ventilation. So that is the theoretical benefit of using high-frequency oscillation. What determines oxygenation in these patients? Obviously, higher FiO2, better oxygenation. But the higher mean airway pressure, the better the oxygenation. Alveolar recruitment maneuvers have been described by some protocols, but because of the bad press from the Oscillate trial, and we'll talk about that in a second, we are restricting the alveolar recruitment maneuvers to very extreme circumstances. The I time can also be increased to improve oxygenation, but we only allow it to be used in one instance in our rule set. What about ventilation? So the power of the piston on the oscillator determines how far the piston will move, and increasing that power increases the amplitude of movement and therefore improves the ventilation. The other is the frequency, which has an inverse relationship with ventilation. The lower the frequency, the more the ventilation. And the reason for that is that when you keep the I time about a third of the respiratory cycle, when you decrease the frequency, there's more time for exhalation. And you can affect the I time too for ventilation. Counterintuitively, the higher the I time, the better the ventilation, but we don't allow that in our rules. Cuff deflation is another way of doing it. You basically induce a leak around the cuff of the endotracheal tube to allow dead space CO2 to get out of the lungs. And then we tolerate a significant degree of permissive hypercapnia. Outcomes. So we'll look at 3 important studies in this regard. The MODE study was not an outcome study. It was a study to evaluate the safety and efficacy of this mode of ventilation. It showed that patients who were put on high-frequency oscillatory ventilation had an immediate improvement in oxygenation. Within 4 hours, the oxygenation was much better than it was when you put these patients on conventional ventilation. However, it was not sustained. At 24 hours, there was no difference. So you had immediate improvement, but not sustained. 30-day mortality was better in this study, but of course, this study was not done for outcomes. This is just an observation. It was much higher. But notice that conventional ventilation, the mortality is much higher, 52%, than what you would expect. Typically, with ARDS, most studies would say that if you aggregate all patients with ARDS into one category, mortality is about 41% at the worst. So that is much higher than that. And then there was no difference in survival without the ventilator. And in that study, there was no difference in hemodynamic problems. But you will see that that is not the case with other studies. So in the Oscillate trial, which is more recent, it's 2013, it's a randomized controlled study. There were 29 centers in 5 countries. The US was one of them. Canada was another. There was some in South America. There was some in Asia, including one in India. About 550 patients with moderate to severe ARDS were put on high-frequency oscillatory ventilation and or on conventional ventilation. The mortality was so high in the treatment arm that they stopped the trial early. There was more sedation used in these patients. There was more neuromuscular blockade used in these patients. There was more vasopressors used in these patients. This is very important because in the same issue of the New England Journal, the OSCAR trial was also published, which had starkly different outcomes. About 800 patients randomized to oscillator or conventional ventilation. Same mortality in the 2 arms, about 40%. And they found that they also used a lot more sedation, a lot more paralysis, as well as a lot more vasopressors when they used the oscillator. So why the disparity between the Oscillate trial and the OSCAR trial? To understand that, and this is my answer to those people who absolutely abhor the oscillator, I believe that these 2 trials were comparison of very particular ways of using the oscillator, an oscillator protocol that was tested against conventional mechanical ventilation. In the Oscillate trial, the control arm had higher PEEPs. Remember, these are patients with worse oxygenation than the average ARDS patients because they had a PF ratio of about 150 or less. They had a lot more recruitment maneuvers, and they used this machine, which, by the way, we use as well. These patients had more hemodynamic collapse and pressors in the high-frequency oscillatory ventilation trial. And of course, the mortality in the control arm, if you remember, was less, much less. So what about the OSCAR trial? They used the ARMA PEEP table, much lower PEEPs, no recruitment maneuvers, and they had less vasopressors in the high-frequency oscillatory ventilation arm. It is my feeling that the protocols used in the 2 trials were so different that the outcomes are related to the specific protocols that were used. These patients had a lot more hemodynamic problems. Could they have been treated with more fluid loading, which is what we ought to be doing to patients on the oscillator who become hypotensive? Could that have decreased their mortality? And what about the higher PEEP in the control arm? The higher PEEP in the control arm is what would be recommended for people with severe ARDS based upon the open lung ventilation data. So I think those things are important. The other things that one must consider is that all ARDS is not the same. So when you look at CAT scans of patients with ARDS, some have more heterogeneous disease than others. So the patients with more heterogeneous disease do better with treatment like the oscillator. Of course, we don't get to do CAT scans on everybody, but that is one important difference. Patients who have more localized disease may do better with something like prone ventilation, and we'll look at that in a minute. The use of prolonged neuromuscular blockade. Now, in our experience, and I've done this for 10 years, and Atul has witnessed this as well, we hardly ever use neuromuscular blockade on patients on the oscillator. So in our new protocols, that is not part of the protocol. It's something that has to be added on if the patient cannot be ventilated. And these trials were evaluating patients for the oscillator very early on in their disease. So this was not used as salvage therapy. This is very important because what we are proposing is to use the oscillator to salvage patients who cannot be managed on conventional ventilation. So in a summary, it's effective in improving oxygenation when there's severe hypoxia. the improvement is unfortunately not sustained. Early use may be harmful. Salvage therapy, there is a role definitely in patients who cannot be put on ECMO or some other mode of ventilation, but we don't think that it's going to be ever any study that will be able to compare it with conventional ventilation for salvage therapy, because patients on conventional therapy, when they need to be salvaged, they always die. What about inhaled nitric oxide? In the embryonic phase, the pulmonary arteries are vasoconstricted very strongly. That is to allow the blood to be diverted to the umbilicus. This vasoconstrictive response to hypoxia is maintained even in our mature life. So when a person becomes hypoxic, the pulmonary arteries in the area that is receiving less blood flow become hypoxic, and there's more, become vasoconstricted. And all of us who have happened to do an echocardiogram on patients with ARDS know that these patients have elevated pulmonary artery pressures. So the use of vasoconstrictors is predicated upon the possibility that they selectively will vasodilate those areas which are being aerated. Thereby, you increase the VQ matching in those areas. Therefore, you improve the oxygen transfer in those areas. Therefore, you improve the oxygenation. What we also know is that there's no difference in efficacy based upon some older studies. I know this is disputed by some of my colleagues by their personal experiences, but I have a feeling that those who have used prostacyclins and have not had the salutary effect of prostacyclins may be experiencing inadequacy of dosing perhaps, and that's something that needs to be evaluated. Inhaled nitric oxide can break the back of any pharmacy's budget. We all know that. And there are a lot of people in this room who are smiling right now. And of course, inhaled milrinone is another alternative, and we'll talk about that in just a minute. What about outcomes? In this meta-analysis of several studies using inhaled nitric oxide, this is favors control, which means nitric oxide did not work. So you can see across the board, it did not work in any of these patients with ARDS. But what about patients with very severe ARDS? So this is another meta-analysis that actually broke down patients into all of them, people with PF ratio less than 100, PF ratio greater than 100. In the aggregate, it didn't seem to work. In patients with PF ratio greater than 100, to the right, meaning it didn't work. In this patient, it's iffy, right? So there may be a role for inhaled nitric oxide or an alternative in patients who cannot be, who have a very severe oxygenation deficit. The problem is that the mortality is very significant, and these patients almost always develop renal failure. In a summary, therefore, about inhaled vasodilators, what can be said is that nitric oxide does not help in most cases of ARDS. It may be harmful because there's excess mortality when you look at most of these studies, but it's hard to power those studies, and they have the strong association with renal failure. Inhaled prostacyclins might be equal to inhaled nitric oxide, and we propose to use that now. No outcome studies, to my knowledge. I don't know if somebody else has some other information. And there are no data about inhaled milrinone other than in patients who come out of, LVAD surgery and other cardiovascular surgery. If all of that was depressing, I've got some light at the end of the tunnel for you guys. So prone ventilation. Why do you think prone ventilation works? Is because when you prone somebody, you are ventilating the posterior part of the lung. You have deeper sulci in the back of the lung, so you are now using more, you're recruiting more FRC. So that is one mechanism. These are all theoretical mechanisms, of course. You have improved VQ matching. This has been shown by imaging studies, Doppler studies, etc., that when you sleep on your belly, you have better VQ matching front to back. And then you have better clearance of secretions, and secretions might play a role in oxygenation in these patients, as well as recruitment of relatively spared parts of the lungs. So what this means is that when patients are lying supine, most of the lung water is gravitationally distributed to the posterior parts of the lungs. And when you're ventilating these patients, the brunt of the alveolar distension pressure and the trauma that alveolar distension pressure causes happens to the anterior part of the lungs. So these parts of the lungs are actually diseased lungs and vulnerable lungs. When you flip this patient over, now what you're using is alveoli which were protected because they were filled with fluid. So when this fluid empties and these alveoli are recruited, these patients oxygenate better. What about outcomes? So in this meta-analysis, now this is a meta-analysis with treatment on this side and the control on this side. So small studies, you can see the numbers are very small. They all seem to favor using prone ventilation. In terms of mortality, in terms of 28-day mortality, slightly to the left, I don't know if you can imagine that diamond to the left of the line. And this is a really robust study in about 500 patients at multiple centers, randomized prospective study as well as it can get. PF ratio was less than 150, and these patients were randomized to either 16 hours of prone therapy every day for about 2 to 4 days. There was an immediate improvement in oxygenation, and there was a sustained improvement in oxygenation on day 2 and day 4. They had fewer days on the ventilator. They did not need to be put on some kind of rescue therapy. They had less ECMO used in that arm, and there was no difference in complications. So you would think that flipping somebody, and these people did not have that fancy bed that we have, the rotoprone bed. They were actually flipping patients onto their bellies in their regular bed. And there was no difference in complications. The tubes did not fall out, etc. There was actually a higher incidence of cardiac arrest in the control group. So based upon these data, I would think that prone ventilation is an important part of our treatment options. And this is the survival. Mortality, 16% versus 32%. So a very important step in the right direction coming from recent study. So in a summary, for prone ventilation, I would say that there's an immediate improvement in oxygenation, which is sustained over several days. And there's a significant reduction in mortality in the sickest patients with ARDS when you do prone ventilation. Remember, you shouldn't prone patients with mild ARDS. It may also reduce length of stay on the ventilator and in the ICU, although that part of the data is a little questionable. We come to the last section, which is ECMO, and I think I'm doing well on time. And what is ECMO? Basically, the idea is that you take the blood, deoxygenated blood, out of the venous system, circulate it through some kind of a device where oxygenation happens, and then pump it back into the body. You have at least two different, there's actually another way of configuring ECMO, but these are the commonest, VA ECMO and VV ECMO. In VA ECMO, the deoxygenated blood is taken out of a venous system, usually the inferior vena cava. It goes through the machine and is pumped back into the proximal aorta through the femoral artery. So in the VV ECMO, on the other hand, the blood comes out of the venous system and returns back in the venous system. In both of these configurations, you need at least 2, sometimes 3 cannulae. However, a new option has come about. It's called the Avalon catheter, which is like the dialysis catheter. It varies in size. It's up to about 31 French, although you don't need to use a 31 French in everybody. And it's inserted always through the right internal jugular vein. The tip of the catheter lies in the inferior vena cava, so it's got to be positioned with ultrasound and other guidance. And the tip collects the venous deoxygenated blood. The proximal port is positioned in apposition with the right atrium and the tricuspid valve. So it's got a hole. The hole has got to be in front of the tricuspid valve. So it's a little complicated in how you place it, but the blood is returned that way. So now in the venous system, you're returning the blood back to the lungs, but it's oxygenated. It crosses the lungs before it goes into the systemic circulation. How does it work? Well, it's very simple. Deoxygenated blood goes through a pump. It is then pushed through an oxygenator. It's a membrane. On one side of the membrane, you have the blood going across. On the other side, you have a combination of oxygen and air. Just like with the ventilator, you can tweak up and down the FiO2 on this. And as the blood flows past, oxygen will diffuse across the membrane into the blood, oxygenating it, and carbon dioxide leaves it. This is actually a very effective way of treating somebody with severe hypercarbia. It is not without complications. This is from the New England Journal article. If you're interested, this is a very good review from 2011, and I'm happy to give you the details. This is based upon the ELSO registry, and the complications are many. You have to anticoagulate these patients because you have a foreign body. The circuit, the ECMO circuit, is prone to getting clotted off, and you can have oxygenation failure, life-threatening emergencies. You have to act quickly. You have to have a backup circuit. A lot of things can happen. A lot of things can go wrong. And you can see that the complication rate is not trivial. It's a very significant complication rate. But what about outcomes? Our interest in ECMO comes from a resurgence of its use during the H1N1 trial. And this study, the CESAR trial, pointed this out very well. 180 patients with severe ARDS were randomized not to ECMO, but to be considered for ECMO. So these were patients who were at different peripheral small hospitals. So if they were randomized to be considered for ECMO, they were transferred to a center where ECMO could be provided, and then evaluated and put on ECMO or not put on ECMO. The patients who were randomized to usual treatment stayed in the same hospital that they were, and they were treated with what would be considered usual treatment, which today should be lung protective ventilation. But one of the criticisms of the trial is that we don't know what treatment was used because there were 68 hospitals. They were doing their own things. Out of the 90 patients who were randomized for ECMO, 75% did end up on ECMO, and 15% did not for various reasons. Either they didn't qualify when they were evaluated, or there were some contraindications to ECMO. There was a significant survival benefit in patients who were placed on ECMO compared to the controls. But obviously, one of the criticisms of this trial is that you're not evaluating ECMO, you're evaluating somebody who is moved to a center where ECMO can be provided, where you also may be able to provide better lung protective ventilation and better standards of care. So that was the biggest criticism of the study. But they did show, without powering the study adequately for it, that those patients, those 75 patients who ended up on ECMO, they had a better chance of survival than those patients who did not. They also did this fancy quality of life assessment and cost of ECMO, because ECMO is very expensive. And they figured that at 6 months, if a patient survived for 6 months, ECMO was cost effective. Those numbers are too complicated for me to understand. I'm not an economist, but some economists did give their stamp of approval. So this is the outcome, survival outcome on those patients from the CESAR trial. And you can see that patients with ECMO had better survival than patients who did not. But this red line is actually those patients who were transferred for ECMO, not patients who had ECMO. The other important caveat is that the mortality of the patients who remained in the treatment arm at their local hospitals was much higher than those patients who were transferred and treated without ECMO at this hospital. Small numbers, not powered, but that's important. The ELSO, which is an organization that supports the use of ECMO, it maintains a registry. So anybody who has ECMO and subscribes to the ELSO will provide numbers. And what they have published, and this is quite recent, this is after the 2009 H1N1 epidemic, they found that the survival of patients with severe hypoxic respiratory failure who were put on ECMO was 52% for respiratory ECMO. Cardiac ECMO, which is VA ECMO, which is used in patients who have circulatory failure. So patients with shock cannot be treated with VV ECMO. They would be on VA ECMO. They had much lower survival. And when you use ECMO for eCPR, which is extended CPR, the survival was very dismal. Going back to this, this is my concluding slide. Always treat patients with what we know works, which is lung protective ventilation. Constrain the inflation pressures by keeping the plateau pressure less than 30, less than or equal to 30, and use tidal volumes that are close to 6 mL per kilogram. If you cannot ventilate those patients, you cannot oxygenate those patients, they have severe hypoxia. If you have ECMO at your facility, consider them for ECMO because there's a lot of legwork that needs to go into putting somebody on ECMO. You need to have a team, you need to cannulate those patients. A lot of things need to be done. Let's say, for example, you wanted to do the Avalon catheter. You have a central line. You got to move that. You got to have the internal jugular ready. You have to have perfusionists ready, et cetera, et cetera. So while you're doing all of those things, you need to make sure that you have a game plan for addressing the patient's hypoxia. And we do. We have means of optimizing the PEEP in these patients. And we would use one of those measures, which is incremental PEEP, decremental PEEP, stress index measurement, and or if you had esophageal balloons, then you would use that to figure out whether your plateau pressure was representative of alveolar distension pressure or not. And you keep reassessing the patient and the patient doesn't improve, then you would look for contraindications for ECMO. If the patient did not have contraindications for ECMO, that patient would end up on ECMO. And if that patient did have contraindications for ECMO, we would use one of the salvage therapies. We know the data is not robust, but without it, patients would die. That is our proposal. And with that, I'll thank you for your attention and take any questions you have. Thank you. So our ECMO program is not up yet. We are in the planning phases of that program, but yes, we intend to use it. Thank you.
A couple questions for you. In terms of the Woodward paper regarding susceptibility for early ARDS, what are your thoughts on the benefits? Is it a drug? Is it effective drug? Is it effective controlling their
Yeah.
pressure for that planet that adds to that mortality benefit? Because you don't see it immediately. It's 15 days later. It seems odd to be comparing.
Yeah. So I think the most damage with ARDS, most people will agree, happens when the patients are most vulnerable. So you have difficulty oxygenating these people. You are using inflation pressures that may be harmful to the patient, and you may have the shear force of distension and collapse. So by you and to top it all off, you have an oxygen deficit, which is being caused by the work of breathing. So I think a combination of things, which when it's used early on, causes the oxygenation to improve. You use less inflation pressure because you don't have to fight the patient's own efforts of breathing, and you're decreasing the oxygen demands of the patient. So all of those factors might be contributing to its benefit. When you use it late, I think you already have caused the damage in the lungs. Therefore, it may not work late. Some people have speculated that cisatracurium per se, not other paralytics, may actually be specifically beneficial and may have anti-inflammatory property. I have not seen any strong data. That's a speculation, I think. But if you know something, I'd be very interested to know about that. One other important factor is that many of these patients have either renal dysfunction or hepatic dysfunction. Cisatracurium is a unique drug because it is not eliminated by either the kidneys or the liver. It is eliminated by Hoffman elimination, which is a process that the red blood cells use to eliminate the drug. So it is a drug that can be used in patients who have multiple organ failure, which most of our patients do. So I think that may be another reason why it works well. I'm so sorry. The question was with regards to the study in which cisatracurium had a salutary effect on survival in early ARDS, when it was used early in ARDS, what is the mechanism by which it might work, and is it specific to cisatracurium? Still being talked about, but it will probably be the CV-ICU and maybe the CCU.
Question, but I'd love you to touch base on the potential for the ability for people to actually
So Wendy's question was a very important part of why ECMO might work in these patients is that you can mobilize these patients. So one of the biggest drawbacks of our conventional way of treating respiratory failure is that we restrict our patients to their beds by need for safety, etc., but also because we're doing a lot of things to these patients. And they are on medications like steroids and other medications which cause myopathy. And eventually, these patients do not die from their disease, but perhaps from their lack of movement and strength and prolonged respiratory failure and the sequela of that. One of the consequences of using something like ECMO is that patients on VV ECMO can actually be taken off the ventilator. If you do it well, they can be on minimal ventilatory settings, they can be extubated, and they can be walked with their ECMO running. So these patients do well theoretically because of that possibility. So I'm trying to remember the name of the study. It has a fancy name, but that studied a drug called lyophilized or something like that, and it showed no difference in outcome when you use that formula. So that's been abandoned. Miguel? The Mackay ventilators? Okay. We have some Avios? Okay. Okay. Thank you for that information. So what Dr. Reyes is drawing to my attention is that Care Fusion has a ventilator. It's called the Avio. Is that what it's called? Or Avia. And they are the ones who manufacture the esophageal manometer balloon, and we have some machines. So if you have a patient who is a candidate for that, we could use that machine. And this is at Cobb as well as Kennestone? Okay.
All right. Thank you so much, Dr. Saberi.
Thank you.
At this time, we just want to do the raffle real quick to finish up.